Welcome, everyone. Thank you for joining us today for our next video capsule as we look at enfortumab vedotin adverse events. Today, we'll be talking about hyperglycemia. I'm Nimira Alimohamed. I'm a medical oncologist in Calgary at the Tom Baker Cancer Center and a clinical associate professor at the University of Calgary. I'm thrilled to be joined today by Dr. Mina Woo, who's an endocrinologist in Toronto. She's a professor at the University of Toronto and director of the Banting Invest Diabetes Center. We're very lucky to have you here today with us, Dr. Woo.
Thank you, Nimira.
So this is kind of the fourth installment of these video capsules, helping us understand these adverse events related to enfortumab vedotin a little bit better. We're going to talk about hyperglycemia today. I wanted to remind us all of the efficacy that was demonstrated with enfortumab vedotin. This is from the pivotal phase 3 study looking at EV in the third-line treatment setting or post-chemotherapy, post-immunotherapy. Enfortumab vedotin single agent was compared to dealer's choice chemotherapy. Here in Canada, in that setting, prior to this data, we were using taxane-based chemotherapy, so docetaxel or paclitaxel. This study demonstrated that a median overall survival with enfortumab vedotin of 12.9 months compared to 9 months with chemotherapy. This translates to a 30% reduction in the risk of death with EV versus chemotherapy, and that hazard ratio is 0.70. This was a large study with over 600 patients. This was the primary endpoint of the study, and this was the intention to treat analysis with a median follow-up time of 11.1 months. When this data was presented, it has very quickly become incorporated into our treatment algorithms, and most of us are using this across Canada, across North America, as part of our standard treatment algorithm for patients with advanced or metastatic urothelial carcinoma. With a median follow-up period that was longer, so on extended follow-up, we can see that that hazard ratio kind of remained the same, which is always encouraging to see. And that difference in terms of median overall survival with enfortumab vedotin compared to chemotherapy is close to 4 months. Notably, when we look at response rates, so how many patients respond, if we look at EV monotherapy alone, and now this is looking across a different study, EV 103, cohort K, which was looking at EV plus pembrolizumab, as well as EV monotherapy. If we look at EV monotherapy, we're expecting a 45% response rate, which is remarkable in this patient population. The combination of pembrolizumab, we see a response rate of 64.5%. You know, these responses are seen in patients who are traditionally in that poor prognostic category, so with liver metastases. What's encouraging from cohort K data is that, you know, this activity is consistent with prior results that we're seeing in the second line and beyond in this disease. So pretty encouraging efficacy data. And what about adverse events? And this is really kind of the meat of what we're going to talk about today. In previous video capsules and modules, you've heard about some of these other adverse events, notably skin reactions, peripheral neuropathy, ocular disorders, and some infusion-related reactions. The majority of treatment-related adverse events with enfortumab vedotin are grade 2 or less. Skin reactions are seen frequently, especially when we add in the combination of pembrolizumab, and peripheral neuropathy is the most common reason for treatment discontinuation. If we focus here on hyperglycemia, and if we look at the combination of EV plus pembrolizumab, it's a small number of patients, and this is from the cohort K data, we can see that 14.5% of patients had any hyperglycemia, and grade 3 or higher was close to 7%. If we look at EV monotherapy alone, there's about 10% of patients who will develop grade 3 or higher hyperglycememia. And Dr. Woo, this is where we really are learning to call our endocrinology friends and lean on their expertise on managing hyperglycemia. So here's a little bit more granularity in terms of treatment-related hyperglycemia from each of these studies. So EV301, which was the phase 3 data, EV201 cohort 1, and 201 cohort 2. This is all grade hyperglycemia. The red bar here is patients who received chemotherapy. So if we're just looking at patients who received enfortumab vedotin, you can see here that the percentage of patients who have any grade of hyperglycemia, 6 to 11%, and grade 3 or worse is in that 4 to 5 to 6% range. In EV301, there was one death in the enfortumab vedotin arm related to hyperglycemia. In EV201 cohort 1, there were no grade 5 hyperglycemia events. There was one grade 4 event in a patient who did not have baseline hyperglycemia. Treatment was discontinued in this patient with enfortumab vedotin, and the patient later recovered without needing ongoing or lifelong anti-hyperglycemic therapy. In EV201 cohort 2, there was one treatment-related grade 4 hyperglycemia. This patient had an elevated BMI at baseline and developed treatment-related grade 4 hyperglycemia and had fatal metabolic acidosis. So this is an important toxicity for us to recognize as clinicians as a possibility so that we can act sooner and receive the right help for our patients when we need it. It's important to note that two factors are associated with a greater rate of treatment emergent hyperglycemia with enfortumab vedotin. The first one is having baseline hyperglycemia, as well as a baseline BMI that's elevated. So in the EV301 study, in patients who had baseline hyperglycemia, so they had elevated glucose levels at baseline prior to treatment with EV, had a 38% risk of developing treatment emergent hyperglycemia, compared to only 6% of those patients who did not have baseline hyperglycemia. Similarly, it was noted that patients who had an elevated BMI at baseline above 30 kilograms per meter squared had a much higher risk of developing hyperglycemia with enfortumab vedotin. In terms of the time to onset, when does this occur for our patients? The onset of hyperglycemia typically occurs during cycle 1. So in the metastatic setting, if we're using enfortumab vedotin as monotherapy, the treatment regimen is intravenous treatment given on day 1, day 8, and day 15, so 3 weeks on and 1 week off. Patients are asked to do blood work prior to each infusion, so they're doing weekly blood work when they have their weekly infusions. And it was noted that, it's really in that first cycle. So usually by dose 2 or 3 that we're seeing elevated blood sugar levels. The majority of patients, so how do they do? If they develop hyperglycemia, what happens? The majority of patients in EV201 study had an improvement or resolution at last follow-up. So it's important to note that for the vast majority of patients, this is reversible. Patients improve and they get better. In the integrated safety population, so looking at all of these patients, about 680 patients treated with enfortumab vedotin, less than 1% of patients had to discontinue enfortumab vedotin due to hyperglycemia. And in that integrated safety population, the median time to onset is about 0.6 months. So in that kind of 2 to 3 week mark. So Dr. Woo, maybe I can pause and ask you some questions here. When we're seeing a patient with hyperglycemia or really any treatment-related adverse events, we always pull up our CTCAE definition and grading, and we go by these numbers. So in Canadian values, grade 1 hyperglycemia is blood sugars that are, above the upper limit of normal, so above 8.9 millimoles per liter. Grade 2, which would be 8.9 to 13.9, and grade 3 is higher than 13.9 to 27.8. And for grade 3, our algorithms say that hospitalization is indicated. And grade 4 hyperglycemia would be, and this is a fasting glucose value, grade 4 hyperglycemia would be above 27.8 millimoles per liter. And that's when we worry about life-threatening consequences. In your mind and in your practice, is this a good framework and categories in terms of clinical applicability and when you would be worried?
Right. So thank you for this. So in some ways, yes, this is applicable, but in terms of, let's call it diabetes control, because I noticed that, in your sort of description of hyperglycemia, we as endocrinologists that treat this condition, which is the chronic hyperglycemia, we usually call this diabetes, right? And basically, by definition, even grade 1, if we could measure it greater than 8.9 fasting on 2 occasions, by definition, that would be diabetes. And in terms of the framework, I think the term diabetes might be more relevant because hyperglycemia doesn't really sort of describe the chronicity of the condition, right? And, it's really hard for me to delineate whether this is a chronic phenomenon or whether this is a one-time phenomenon. And this one time, even though, you did preface by saying that this is a fasting measure, doesn't really give us a sense of the severity of the condition. So I do get a lot of referrals from our cancer centers here, not necessarily for this particular drug, but also including this. And really, we would try to figure out whether the patient would have diabetes or not, right? And what would be more helpful in terms of grading would be to get an A1C level, right? And this would really give us an idea of the chronicity and severity all at the same time, okay? So that would be very, very helpful. And then the other piece of information that would be very helpful for us in terms of guiding the management is to look for endogenous insulin levels. So most of the cases with this adverse event, this is usually driven by the insulin resistance as opposed to insulin deficiency that's driving the hyperglycemia. And, if we are to, let's say, measure C-peptide levels on top of A1C, this would really give us a very sort of clear framework as to how severely insulin resistant they are and how severely hyperglycemic they are. And that'll really dictate whether we need to really work on diminishing their insulin resistance as opposed to providing insulin. And these are two very separate therapies. And, if they're highly, highly insulin resistant, then even giving very, very high doses of insulin may not necessarily work in driving down this very severe hyperglycemia, right? So those are the important comments that would really, even, when you want to refer the patients, in terms of referral, unless you've got some specific guidance and training to treat diabetes, I might get in trouble for saying this, but really even grade 1 here would likely translate to A1C of 7 or 8%. And clearly at this severity even, they would require treatment, right? So
that's exactly it. I think many of us are a bit removed from our internal medicine training.
Absolutely. Listen, and this is what we do. This is bread and butter, right? For us. So, this is important that we work as a team, right?
Yes.
But in terms of helping to try to figure out sort of which directionality we need in terms of therapeutic interventions, those few parameters that I mentioned earlier would really help us.
That's a wonderful reminder. So in addition to checking their fasting glucose, we're checking their A1C and their C-peptide levels.
I always ask for those when I get a referral.
That's
from
wonderful.
Oncology colleagues, yeah.
The other practicality, I guess, that I wanted to touch on is, for our patients in our lab system here, we're not getting fasting glucose levels.
And I don't think that's necessary, to be honest. And that's why I'm a big fan of A1C rather than fasting, because, these patients, they're going through a lot. And for them to, undergo fasting, especially when we could get useful information without them going through fasting, fasting is actually not all that useful. It will be useful if we're trying to figure out insulin dosing and things like that. But for us to get an idea of the severity of diabetes or hyperglycemia, A1C would be useful. I mean, mind you, there are caveats, right? Like these may be very sick patients and they might have anemia and, with hemoglobin production. And so there are some caveats, but in general, I haven't really had any issues with unreliability of A1C, even in the oncology cohort.
Fantastic. On the clinical trials, and similar to what we do in practice, this non-fasting blood glucose is checked prior to each dose. So that's what's on my standing lab rec.
Yeah.
And it's really sort of that trigger of 14 or higher millimoles per liter.
Exactly.
Then when I raise my eyebrows and it alerts me that we need to intervene.
Yes, exactly.
And then I call endocrinology right away, because as we just mentioned, that we're far removed from novel medications, from all of these nuances that you, the expert, are very familiar with. And so I'm always happy to call.
Yeah. So again, I bring up this point that this one level of 14 millimoles, it is definitely a red flag. But that in conjunction with A1C and CP peptide would be much, much more meaningful because, technically, if they just had, let's say, a donut prior to them having their blood work, then they would get a glucose level of 14, right? So to sort of get away from that one-off and to avoid sort of repeated measurements, A1C would sort of give us some more sort of conglomerate, chronic, level of the glucose levels, because glucose is sort of like a compound, chronic, cumulative phenomenon, and we don't necessarily care about that one time, one moment.
And when we see these patients, we think about, do they have diabetes? So if I see that level on my lab results, I think, do they have underlying diabetes?
Exactly.
Are there other risk factors like illness or infection? Have we recently given them systemic steroids? So, in our current clinical practice, we're using enfortumab vedotin after chemotherapy and after checkpoint inhibitors. So some of these patients might have had checkpoint inhibitor-induced itis of anything that we needed to use steroids for. So we always have to think about that as well.
Yes.
Okay.
And that knowledge will also really help us guide sort of what type of diabetes we're dealing with, right? So for example, with not as much with pembrolizumab, but other checkpoint inhibitors, there have certainly been cases where it would induce sort of type 1 diabetes like picture, right?
Right.
With but that's sort of more rare. And I think here we're talking more about sort of insulin resistance and type 2, sort of the more common type, where the treatment strategy would be very different than going straight to insulin.
I think the mechanism of action of why enfortumab vedotin does this is not clearly understood. So I think we just have to, listen to our patients and counsel them, especially for those who have baseline diabetes, right? To really monitor their glucose levels, monitor their symptoms. So it might mean that checking more frequently than they used to at home.
Exactly. And don't forget, diabetes, even for the general population, can get unnoticed, right?
Right.
So they could have, undiagnosed, predisposed diabetes. And so even for these patients, it would be good to ask whether there's family history of diabetes, whether there is, underlying obesity, and other features of metabolic syndrome. And these would, sometimes push them to diabetes with this particular therapy, right? So it's really important of their sort of underlying conditions that could predispose and to exacerbate or sort of unveil, if you will.
Yeah, unmask it. That's a really good point. So back to our histories where we're asking about that family history.
Exactly, exactly.
And, I think the important thing to remember is that, this will happen infrequently, but hyperglycemia can lead to ketoacidosis. And that's why we need to be cognizant. We can't ignore those elevated glucose levels that come across our desk or those patient symptoms.
Absolutely, exactly. And especially because, I mean, many years ago, they would have like a cover of the Times magazine, and diabetes is a silent killer, right? Because unless we measure it, it can often go unnoticed, right? And it is, especially if it sort of happens slowly over time, then they are not going to get the textbook symptoms of polyuria and polydipsia and things like that. So it will go unnoticed, and this is why it would be important to sort of screen them, especially if we know the frequency of diabetes that can occur with this particular therapy.
So I guess I wanted to ask you, Dr. Woo, when I see these elevated random glucose levels,
Yes.
At what level in a patient who does not have underlying diabetes, I see a random glucose across my desk, what level should I send them to the hospital for inpatient management versus, okay, we can sort this out at home?
Right. So a few things. One is, one value of 14 plus is enough to, get your suspicion high.
Mhm.
But really, I would repeat, and also at the same time, in the same poke, order A1C and C-peptide. And this will really get to the bottom of whether this is a real deal or whether it's a one-off because of many reasons that sugars could go up. And the other thing that I would like to bring up here is lifestyle. Okay, so, of course, this is not the patient that I'm going to send them to exercise or to diet. So that's not really what I'm trying to say, but it is important for the patients to know some very low hanging fruits, if you will, no pun intended, but, suspect, food habits or dietary habits that they could perhaps fix that could, easily manage their sugar levels. So for example, are they having lots of pop or juice or lots of sweets? I mean, these are sort of the obvious ones, but then also a lot of people don't realize that a lot of the starchy foods or the processed carbohydrates like breads or pastas, rice. I mean, these are very common foods that people have, especially, many of the ethnic groups. So, if they know that and they did not know prior, and many people, they do not, right? They could sort of attend to these particular food groups, and that could be very effective in lowering their sugars before we start going into pharmacotherapy. Okay. And then the other piece is physical activity. So, I'm not an oncologist and I don't really have a good sense of how sick they are, right? So obviously, if they're frail, if they're feeling unwell, I'm not going to tell them to run a marathon, right? But if they are reasonably well, and the patients that I see, even from the oncology clinics, they're all walking into my office and they're quite well, right? And it's really important for them to know that just walking, right, just being physically active as opposed to being sedentary could go a long way in terms of bringing down the sugar. So these are sort of, generalized health advice in some ways, but particularly when it comes to managing diabetes, we often forget, right? Because these are such basic information that's sort of good for everybody, right? But when it comes to sort of glucose lowering effects, it is actually quite important. And for some people, these simple advice and just spending 5 minutes with what I just said could sort of bring down their sugars right down, into single digits.
Exactly. They can be so impactful.
Exactly.
When
So,
we,
just switching from like juice to water
yeah.
or from pop to milk or, something like that, they could, it's definitely a good start.
And our sort of algorithms for what to do with the enfortumab vedotin treatment if they develop hyperglycemia. So if a patient has grade 1 or grade 2, we would usually continue at the same dose level while managing this treatment related adverse events. But if we're up to the grade 3 level, we withhold treatment, manage the adverse event, and then usually you can resume at the same dose level once their glucose has improved and the patient is clinically and metabolically stable. If we're getting those critical values, so grade 4 or higher, then we would discontinue treatment if it was a true treatment related adverse event.
Sure. But the other point that I would like to make is, like, hyperglycemia, it is very treatable, right?
Mm-hmm.
So there are multiple treatment strategies, and of course insulin for like at whatever dose will bring down the sugars, right? So it is very, very treatable, and I would push to get this treated so that it doesn't delay their cancer treatment.
Exactly. And I think that's the most important point is, we have to be, as clinicians seeing these patients or having them call in, we do need to be attuned to those symptoms, like the polyuria, polydipsia, the confusion, even more extreme, when we're seeing a DKA clinical presentation, the weakness, dry skin, dry mouth, the fruity odor of the breath. When we hear those or see those, we really need to be attuned to act quickly, knowing that the sooner we treat this adverse event, the sooner we can get back onto their anti-cancer treatment.
Absolutely.
I think we've talked a lot today about hyperglycemia and how we help our patients and when to call experts like yourself, Dr. Woo. And you very nicely highlighted the three kind of components that are really important is educating our patients on the signs and symptoms and self-monitoring their blood glucose in those patients who are known to be hyperglycemic at baseline. You've very nicely elaborated on the diet and lifestyle modifications that sometimes we forget to mention and to really harp on. There's a lot of good evidence for the benefits of exercise in patients with metastatic disease who are on treatment. So that is really important. And then the pharmacologic interventions, which is when we need to phone a friend.
Mm-hmm.
Yes, that's great. So did you want to add anything else about the management of hyperglycemia with enfortumab vedotin?
Yeah, so, I agree with you. I think the exact mechanism of action as to how they become hyperglycemic or diabetic is not entirely clear, but just from my sort of quick sort of perusal, my understanding is that it's more at the side of the insulin resistance rather than sort of insulin deficient type of diabetes. So this is where sort of lifestyle and increasing physical activity and avoiding these very processed carbohydrates and glucose would sort of go a long way before jumping to insulin. There are very, very effective oral medications that would sort of address sort of the insulin sensitivity piece, but these can be very sick patients, in which case we tend to withhold these until they're sort of more clinically stable. So so it all depends, and this is where, I'm happy to sort of see them. And if I feel that this treatment will be going on for a longer time, and if they're sort of perfectly stable and out in the community and sort of up and about, then I wouldn't actually hesitate considering some of these oral anti-diabetic agents. But if they are sort of more sick and they're hospitalized, then that's not where we would typically start these oral meds or weekly meds. And we would stabilize with insulin. And then once they're out in the ambulatory setting, this is where we would then consider more chronic therapy with sort of more easier, lots of new drugs like SGLT2 inhibitors and GLP-1 receptor agonists. And so these, but when in concert with the cancer therapy, it might complicate things. So we wouldn't want to complicate your, oncologic treatment, right? So we would sort of focus with insulin because that's sort of the safest and it's more dialable one way or the other. But then once they're, out in the ambulatory setting, and if they still have diabetes, then, it would be not that different than our strategies to treat our sort of garden variety, if you will, type 2 diabetes.
Dr. Woo, thank you so much for joining us today and for your expertise. I've learned a lot on how we can help manage these patients better and work together with our endocrinologists to ensure that, we keep providing anti-cancer treatment that's effective, but also managing the toxicities that may come up. So thank you all for joining us today.
Absolutely, my pleasure. Thank you so much.